So thank you, everyone. I'm really happy to be here today. It's quite an honor to be in this group of very distinguished lecturers who have come to this university as Levitt lecturers, and hopefully at the end of this you'll feel that, as Frank does, that this was time well worth spent. I'm going to talk about unconscious racial bias in clinical decision-making. And I think the context for this is very important. The context for this is the fact that there exists tremendous health equities in this country. We know from our studies that the African American population dies at a much higher rate than the white population. We get sicker at a younger age and die at a younger age than the white population. And this is true in many, many different disease categories: diabetes, hypertension and stroke, some cancers. You can go down the list, and it's always around twice the figure. That being said, I believe that we can do something to improve those inequities. We as clinicians and we as people who are part of a much broader healthcare system can do something to really turn this around and eliminate these health inequities. In order to do that, however, we have to start from an understanding that the health inequities are not the result of biological differences between the racial categories. As it turns out, there's only one race, the human race, and there's lots of different populations within that race. We have different histories and so on, and those histories may have some impact on health outcomes, but there's no qualitative biological differences between those racial categories. The health inequities that we see in the African American community, in the Latino community, and other racial and ethnic communities, those health inequities are a particular instance of the social inequities that exist in our society. Things like the lack of employment, poor housing, poor education, lack of insurance. This, in fact, is something that's not just a problem for communities of color, but for other populations as well. So in rural white America, this is a huge problem. If you looked at the health statistics in Appalachia, if I showed you, say, cancer deaths in Southwest Virginia and didn't tell you it was Southwest Virginia, and showed you the same stats on inner city Baltimore, they'd be pretty much the same. The difference is that the population attributable risk, for those of you into epidemiology, is much higher in the African American community or in communities of color. So the likelihood of being poor, without a job, living in poor housing and so on is higher in those communities because of racial discrimination. I said there's no race other than the human race, but there's plenty of racism and directed at these different social categories. And until we deal with that, we won't really eliminate the health inequities. Part of the problem about health inequities, however, is not just that sort of structural stuff that I just spoke about. A lot of it, a significant part of it, has to do with the way in which healthcare is delivered. Okay, so while lack of insurance, poor jobs situation, affordable housing sets these communities up for their health inequities, even in the situation where they manage to get in the door, the way they are treated is different. Before I get into the specifics around these issues of racial bias in clinical decision-making, I think it's important to have some background on how human beings think. Daniel Kahneman is a world-famous economist. He's a behavioral economist, got the Nobel Prize along with, what was his partner's name? Amos Tversky. So he's very well known. He wrote this book. If you haven't read this book, please do. It's a great book. In this book, he talks about fast thinking and slow thinking, system one thinking, the fast thinking, versus the slow system 2 thinking. System 1 thinking is automatic, habitual, not really thinking at all. It's automatic. And we need that thinking very much. Yeah, you can imagine how much effort it would take to think about how do I do this thing of walking forward. If I had to think about all the stuff that it takes to do that, it would be wasting a lot of my energy, right? In times of great danger, you don't want to have a big debate with yourself. You want to get out of danger. How many here are clinicians of any sort? Nurses, docs, whatever. As clinicians, we're trained. The difference between a really great diagnostician and those of us who struggle to be that way is really system 1, right? They walk into the room and they get a picture and boom, they know right away. And we all know some of that, right? As clinicians, you walk into a room, someone's sitting on the exam room bed, you're bent over, huffing and puffing and breathing really hard and working hard at it. Before you even open your mouth and ask them a question, you have a differential diagnosis in your head, don't you? You already do, just based on the pattern of what you saw. And that's system 1. System 2 thinking is what we all think about as thinking. It's rational, slow, deliberate. And we think, of course, that most of our time, we spend our time in system 2. And the truth is the opposite. The majority of our time we spend in system 1. At the University of Virginia, there's a guy by the name of Timothy Wilson, who for many years was the chair of the Department of Psychology. He was the person in social psychology who started a real revolution around implicit cognition. They talk about the fact that implicit or unconscious thinking driving human behavior. And he wrote this book back in 2002, Strangers to Ourselves, where he explains that the majority of our waking life is spent, he didn't call it in system 1, but is spent driven by unconscious cognition, habitual thinking. Further work in his lab in implicit cognition was done, and some of it led to a lot of work around implicit racial biases and other implicit biases, popularized by Malcolm Gladwell in his book, Blink. Very nice read. A lot of that work was done at the University of Virginia. Some of this it's important for us to understand it's actually hardwired in. So we're going to play a little game here. I'm going to see if this mouse works. It's not working. This one works. And I'm going to point to a color, and I want you to say the color. And we're going to do this real fast. Okay? You ready? Go. Okay, that's blue. Go. Say it.
We're not seeing the pointer.
You can't see the pointer? Oh my word.
There you go.
Okay. So you're ready? I was a Boy Scout. Okay, so here we go.
Blue, green, yellow, green, red, green, blue, red, yellow, blue, yellow, red.
Fantastic. I can see the mountain air has really helped here. We're going to do the same thing. I want you to say the color. I don't want you to say the word. Okay? Just the color. Go.
Green, blue, red, yellow, red, blue, green, yellow, green, red.
Fabulous. Same rule. I want you to say the color and not the word.
Red, green, red.
That's called the Stroop effect. Most of you, like me, are probably expert English language users. Our reading system in our brain is automatic. You see that word, you can't say ignore it. You read it. So you get two conflicting instructions. say the color, and your brain is saying, say the word. And you have to overcome that. And it makes you stumble because it takes conscious effort to overcome that automatic system one thing. The system one functions in our brain are there for a reason. Evolutionarily, I know that it was important to recognize patterns in the world. Okay? Was that movement in the shadows something I should be nervous about? Should I get the heck out of here? Or was that just the wind blowing the leaves? Right? So we have this situation here. This is from MIT's neuroscience lab. You look at this, you see the pattern. Your brain has to figure out, okay, where's the shadows? We see that shadows have blurry lines, so we can sort of see that there's a shadow there. And it's helped out by the fact that the shadow-producing object is right there. So we know that's there. We know that things in shadow that are lighter than surrounding things in shadow are probably brighter than average. And on top of that, we see in other parts of this pattern that light square is surrounded by darker ones, so this is probably very much like that. Right? So we say that's the same as that and that and that and that. That's what our visual system tells us. When in fact, it's the same, it's a dark square. If you were to take a camera and take a picture of that, the camera, not having a brain and a visual system in its brain, would just show you what the light says, and the light would tell you that it's the same color. So that's perception. And there's some things hardwired into our perception, but there are other things that are hardwired into our brains, and one of them is stereotypes. So they did this study a while back, and they asked the participants, here's a baby girl named Debbie, and she's crying. What is she feeling? Yell out some words. Hungry, tired, wet, sick. A lot of people said afraid. Then they told another group of people, here's this crying baby. His name is Danny. What words do you think came to their mind? Mad. Angry was the most often used one. There was a gender bias there of how this baby was feeling. So who cares? We got some hardwired perceptions in our brain. We got some stereotypic thinking. A lot of folks who are interested in this in social psychology start doing work around it, as I said, at the University of Virginia. Even though Project Implicit is supposedly at Harvard, the servers are actually in Gilmore Hall at University of Virginia. The three people who are pretty big in this area of research are Tony Grunwald at the University of Washington, Masrani Banaji at Harvard, and Brian Nozick at the University of Virginia. And Brian runs all the computers for Project Implicit, which you should Google sometime and go to. The thing we did with this droop effect with the colors, that's the basis on which the implicit association tests are done. This is a psychometric test that plays on the fact that if you are trying to make an association that goes against some unconscious view, you have to override that unconscious view in order to do the right answer. So they'll show you pictures of white people, and you're supposed to associate bad things with that. For a lot of people, that's hard to do. Or I shouldn't say it that way. It's harder to do than it is to associate bad words with black faces. It's harder to associate good words with black faces. And even if the amount of time it takes you to override that bias is a few nanoseconds. The computer knows it. And that's the basis of these tests. So they do all kinds of tests. They have about 100 of these IATs. Gender bias in science is real big. Most people, and millions have been tested here at this site, think that women aren't capable of dealing with math and science. Unfortunately, that's also true for most women. They have that same bias. Stereotypes are very well known. One of the important accomplishments of the civil rights movement is that the overwhelming majority of people in this country, including the overwhelming majority of whites, are explicitly anti-racist. But if I were to hand you all a sheet of paper and say to you, write down all of the racist stereotypes you can think of about black people, you could fill the page, right? So even though you don't believe it explicitly, you know what all those stereotypes are. They exist in our society. And they're reinforced constantly. In the books we read, the movies we see, the newspaper, the TV news. This is from Katrina. And AP, African American, young man walks through Chesapeake floodwater after looting a grocery store, blah, blah, blah. 2 whites. 2 residents wade through Chesapeake water after finding bread and soda. This happens all the time. All the time in the news. I mean, I cringe when I hear about some murder. Please don't let it be a black person, right? Because that will be all over. So the implicit association test for implicit racial bias has been given at this point to about 20 million participants. This is a very robust finding that the majority of whites are pro-white. Unlike women, it's not the majority of blacks, but there's still not an insignificant number of blacks who also have that same bias. Why does it matter? The title of this talk is the impact of racial bias on clinical decision making. Back in 1999, Kevin Shulman and his crew showed up at the American College of Cardiology. And they brought a bunch of cardiologists together, and they presented them with a video clip of someone coming into the ED with classic symptoms of a heart attack. Back then, standard of care, when someone showed up in your emergency room with what looked like a heart attack, was you gave him or her an aspirin, and you took him to the cath lab. Right? So he asked them, what would you do? Here's the situation. What's your response? The only thing that changed in the experiment was that sometimes the actor playing the patient was black, sometimes that actor was white, sometimes that actor was male, and sometimes that actor was female. And you can guess the order in which people were most likely sent to the cath lab. You can probably say it with me. It's white male, black male, white female, black female. There was both a racial and gender bias, and that's what he wrote about in this lead article in the New England Journal. And those of us who were around will remember all hell broke loose. How can you possibly say that it was racial bias that did this? You don't know. There's no way you could measure this. This is just supposition on your part. There's all kinds of other factors involved that people would be coming up with these things. That Shulman study was replicated, how many times, Matt? Like 5 million times? I mean, they did that study over and over again. And in 2003, when the Institute of Medicine published this book on unequal treatment, a huge chunk of the evidence that they used to talk about racial bias and prejudice in clinical service delivery was based on these studies in cardiovascular medicine. There were replications of the Schulman study. Then in 2007, Alex Green and Masrani Banaji up at Harvard did a study that was, again, another sort of replication of the Schulman study. And what they did, by now the standard of care was if someone showed up and looked like they were having a heart attack, you gave them thrombolytics. So they presented folks with this scenario and asked them what they would do, and then they measured who got sent for thrombolysis. And they found basically the same thing that Schulman had found, that there was a racial bias. The difference here was that with Banaji on board, what they had done with all the study subjects was they had administered the implicit association tests on race. And it turned out that the more pro-white you were, the more likely you were to have the racial bias in your treatment, sending the whites for thrombolysis and not sending the blacks for thrombolysis. So this was the first time that anyone had done a study like this where they had some objective evidence of unconscious racial bias driving the clinical decision. Now, there's been a number of studies since then trying to find a link between implicit or unconscious racial bias and the disparities in the treatment across racial categories. Some have found a link, some have not. Brian Nozick and I did a study a few years ago where we looked at total knee replacement and the recommendation for total knee replacement. African Americans have a much higher rate of obesity than whites, a lot more osteoarthritis. One of the things you can consider for very severe osteoarthritis that's refractory to medical treatment and physical therapy is a total knee replacement. But blacks are far less likely to get a TKR. We said, well, is this because of implicit racial bias? And we talked to a group of physicians, gave them this scenario. We also added in a thing that you'll see there called medical cooperativeness. We asked the study participants whether or not they thought the target, to use the psychologist's word, was someone who would be medically cooperative, would do what was suggested to them. We found that there was no association between how people performed on the implicit association test on race and their decision to refer or not refer. So we were one of those studies that didn't find a link. We found an interesting three-way link, however, with medical cooperativeness. It turned out that if you rated high on pro-white sort of bias, then you were more likely to feel that the black patient would not be medically cooperative. And based on that, you were more likely not to refer them for this therapy. So I said, well, that's interesting. So rather than it being primarily the racial bias, it's shifted to this other factor, which sounds sort of logical, right? I mean, you could think that for good reasons. This is a poor patient, they can't get down to physical therapy, blah, 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 so I'm not going to push TKR on them. And I wondered, along with some other people over in social psychology there at UVA, could this help explain some of the problems that we've been seeing in pain treatment? There's a very long literature in the biomedical literature about the unequal treatment of pain, where there's big disparities, including on things like cancer pain, where African Americans and Latinos do not get appropriate pain treatment. In this study in the Annals of Emergency Medicine, they found that with a long bone fracture, whites would get some kind of analgesic 74% of the time. And I thought that was pretty shocking, only 74% of the time, really. But blacks would only get it 57% of the time. The amount they would get would change too. So in this study, they found that for a limb fracture, whites would get far more morphine than blacks or Latinos. So black patients' pain, apparently, is either not recognized, and because it's unrecognized, it can't be treated, or it's recognized but not treated. And what could motivate that? Why would that happen? And we thought that the reason that could happen is that in a society where there are biases against blacks, what happens in those sorts of things, in that frame of thinking, is that the other loses human characteristics. And once they lose human characteristics, then things like pain don't operate the same. And there's a long, long, long history of this in the United States. And it began with slavery. In order to treat people inhumanely as they were treated in slavery, you have to think of them as not being like you. They are not human, so I can do this. And the whole science grew up around this. From 1799, there were lots of studies on morphology, looking at, and of course the people doing the studies were white males who thought of themselves as being the pinnacle of evolution, and ranked all the other so-called races as being less and less and less and less like them, and less inhuman. This is from about the same time, treatise on tropical diseases, talking about blacks. They bear surgical operations much better than white people, and what would occasion insupportable pain to a white man, a Negro would almost disregard. 1826, in a scientific journal. We come to reflect that all of the women operated on in Kentucky, except one, were negresses, and that these people will bear cutting with nearly, if not quite as much impunity as dogs or rabbits. Joseph Sims, the father of gynecology, developed all kinds of very important techniques in gynecology, operating on slave women without anesthesia. From a surgical textbook, Negroes, they are stoic in their reaction to pain and discomfort, do not easily go into shock, take anesthesia well, resist infection, show remarkable powers of recovery. This thinking is ingrained in medical science. So we said, okay, perhaps beliefs about black and white biological differences will predict whether or not people have an appropriate perception of blacks' pain. And in turn, that would drive their treatment of those patients. And we set up an experiment to do that. So this was published last year in the Proceedings of the National Academy of Science. Now, Frank mentioned that I was chair of the Department of Family Medicine, and when I became chair, that essentially killed my research career. So all my grants had run out and everything. And I had publications and everything for my research. Felt really good as a researcher. All this work we did here, we did on the side with these colleagues across the campus from me there at UVA with no funding. And it gets into the proceedings of the National Academy of Science, you know? I'm like, wow. Yeah. So we did a sort of proof of concept study. We got 120 participants, most of whom were white. And we asked them, okay, if you slammed your hand in a car door, how much pain would you feel? And we asked them to rank that on some measure. And as you might imagine, the subject said it would really, 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 really hurt. And then we would show them a picture of a black person or a white person, or, you know, we did it randomly. And how much pain would this person feel if they slammed their hand in a car door? And you might find it hard to believe, but people would say, not as much. So we asked them about their biological beliefs about blacks and whites. Blacks age more, and remember I told you if I were to ask you to write down stereotypes of blacks, we could all write up a real long list. So that's what we did. We just wrote up a list of crazy shit. Blacks age more slowly than whites. Blacks' nerve endings are less sensitive than whites. Black people's blood coagulates more quickly. The skin is thicker. We put it all down there. Okay. And then said, on this scale here, where do you fall on this? We were particularly concerned about anybody who said anything like possibly true, probably true, definitely true. If you even thought there was a possibility that this is true, you're off, okay? And this is what we found. There was a significant number of folks who believed in these things. I don't know why the thick skin thing really caught on, but they really caught on. And a lot of them believed that was true. Then it turned out that correlated with whether or not they felt that black person felt pain when the door was slammed on their hand. If you had a low amount of those beliefs, then you didn't see any difference. They felt pain just like you. But if you had a high amount of those beliefs, then blacks felt less pain. Yeah, tell me.
Sorry to interrupt very quickly. Where did you select those participants from?
These were lay people.
Okay.
So then we said, well, what about medically trained people? So we got 418 medical students and residents. And we presented them with a scenario, bone fracture, kidney stone, what would you do for this patient's pain? And we also gave them the same questions about biological beliefs. The case we presented was a mock medical case. We didn't present them with a black face or a white face, but we used some keywords. We used so-called black names or white names. That's all we did. That's all. That was the only clue they got that this was a black person. And then we asked them, okay, so this person shows up in the ED, they got a long bone fracture. What would you give them for pain? And they had different choices. We also asked them all those same questions about these false beliefs and biological differences. Now, it's interesting that the first years had a number of these beliefs. And it was pretty similar to the lay public. Thankfully, it decreased over the years of medical education, so we were doing something, I guess. Although it didn't disappear. And we also found that there was a correlation, that if you had high beliefs, you were less likely to give you were less likely to rate their pain as being the same as whites. There was this paradox with low beliefs where they actually thought that blacks had more pain. I think that was a particular glitch having to do with the way the med school classes opened up at UVA. There's a 2-week thing where they do a bunch of stuff around cultural competency and so on, and I think they were sort of primed, you know. So if they had low beliefs to begin with, then they were more likely to sit, you know, I'm going to really, you know, show my pro-blackness here. And they were also less likely to do appropriate treatment, you know, like Tylenol for a femur fracture. So, what do we do with that? That doesn't project very well. Chadwick Boseman, an actor, he plays the Black Panther. How many of you saw him in the Avengers? Good. I cannot wait. This movie opens soon, very soon. It's directed by Ryan Coogler, who did Fruitvale Station. Anybody here see Fruitvale Station? Great movie about cop killing of an African-American youth in Oakland. So I'm expecting great things about this movie, and heaven knows we need some black superheroes. You know, we got a woman now. We're gonna have a black superhero. But when I show up in the ED with a broken femur, please just treat me like a human being and not like the Black Panther. Okay? I'm really not that strong. I am not that strong. So what do we do? I think it's possible for us to actually change implicit biases. It takes work, but we can do it. One of the important ways in which we can change the impact or mitigate the effect of implicit biases is forcing ourselves into system 2 thinking, which requires slowing down. Remember, it's slow thinking. It's stopping. After you have that first impression, it's really just, you know, it's GERD, it's GI reflex. Stop, think. Could it be an MI? Restructuring the ways in which we make decisions. This is real big in the hiring world. Okay, so those of us who've ever been on search committees, we get explained this whole process by EOP, who tells us how to do this right. The Swedish National Orchestra years ago was all male, as were a lot of national orchestras, and they had to have some auditions. And among the auditioners was a woman whose father was on the selection committee. So they put up screens so that the selection committee could not see who was auditioning. And that was the first year a number of women were hired for the Swedish National Orchestra. So there's things like that you can do to help you mitigate against biases. I think there's things in an electronic health record we could do to help forces. Like, did you consider MI in this patient? Whatever. We were talking earlier about humility. I think it's important for us to all realize that we all have biases. Become aware of what those biases are. That's the first step. Understand that they're inevitable, but they're not intractable. You can You can mitigate them, and sometimes I think you may even be able to get rid of them. But it takes explicit practice in order to do that. It takes practice. Remember earlier I said you're hit with those biases and those stereotypes every day, day in, day out. So this isn't like taking out the garbage where you just take it out once and it's done. It's more like maintaining your roof, right? You got to keep at it, otherwise it starts to leak. So every day. Education, self-monitoring, understanding that. Did I really act in an appropriate fashion there? Fostering counter-stereotypical associations is really important. I haven't walked through the halls here, so I don't know if it's like UVA, but UVA, if you walk through the halls of the med school, all you see are pictures of old white men. Everywhere. And I happen to know that there were a lot of blacks who've graduated from there and done great things. There are Latinos who've done great things. There's women who have done great things. I mean, something as simple as just mixing up the pictures, having a different environment around you makes a difference on the sort of cultural climate and environment. That's important. And fostering social connections is really important. One of the reasons why racial desegregation is so important is that it's really hard to think of those people as being unlike you when you're in and among them and they seem to be just like you. Right? It's hard to think of women as incapable of dealing with math and science if you're in a classroom, med school classroom, and it's 50% female, and you know for a fact that those 50% are a lot smarter than you are. Right? So it's important to have those social connections.
Is that your fault?
No.
Okay, sorry.
No problem.
Very sorry.
I think we have to change the way we teach and practice medicine. When I showed you those things from the 1700s, 1800s, into the early 1920s about medicine, we don't get stuff as gross as that usually anymore. But the biomedical literature is written in such a way that it promulgates the idea that there's some kind of genetic difference between blacks and whites and Latinos and whites. It's all the time, right? Because they'll present something like, well, blacks are they have twice the incidence of diabetes. And then they just leave it. Well, why is that? In the context of what we're learning in med school, you begin to think, well, maybe there's some genetic component to that. And in fact, there's a lot of people looking for the genetic component of that, or the higher incidence of stroke, or the higher incidence in some cancers. Meanwhile, no one's trying to figure out, based on skin color, why the incidence of breast cancer is higher among whites. Right? And it is. When they tried to find out the reason for that, they did the appropriate genetic thing. They started looking at specific populations. Genetics have to do with populations and ancestry, not skin color, right? And they traced it down to Ashkenazi Jews. And they identified a gene that was putting people at higher risk. So the fact that in some parts of this country, prostate cancer among African American men is 7 times the national rate doesn't mean to me that just because you have black skin that you are 7 times more likely to have prostate cancer. That's a very poor marker of genetics. Extremely poor. I do believe that there may be some founder population among African Americans who do have a genetic predisposition for that, and we need to find out who they are. But that requires a different sort of study. You need to look at ancestry then. Trace it back to a particular group, a founding group. Is there some, the Igbo in Nigeria, is that the group and the descendants of that group? Africa's a huge place. It is huge. You can fit the United States, Europe, China, Australia, and still have room left over. Okay? So just to say that, I have ancestors who are from Africa doesn't give you much to go on genetically. Okay? You need to get a little more precise than that. Because it makes a difference. And it makes a difference in this country. So the slaves who were brought from the Horn of Africa primarily went to the mid-Atlantic. From Western Africa, what's now Angola, that area, most of those folks went to the Caribbean and the far southeast, like the Gullah Islands and stuff like that down in southeastern United States, and to Latin America. Those people were like 10,000 miles apart from each other, right? They're genetically different from one another in terms of populations. And we need to get that precise if we're going to do that kind of research. So that's one thing we need to do. We need to change our curriculum or curricula across medical schools to get rid of all the instances in which either said implicitly or explicitly that leads people to believe there's some kind of biological basis for the differences in the incidence of disease, the morbidity from the disease, and mortality from that disease. And if you're going to do genetic studies, do it the right way. The other thing we need to do is we need to understand that and teach in medical school the point that I made earlier, which is that these disparities, these inequities, let's call them inequities, are a particular instance of the social inequities, and that you have to address the social inequities in order to deal with the differences in incidence and mortality. And that if you're going to do that, that's clearly something that goes beyond clinical medicine. That the health system ought to include everything that impacts the health and well-being of the population, which means transportation, housing, education, jobs in the economy, on and on. That we need to have what in public health we talk about health in all policies. That the Department of Transportation, when they sit down and think about building a road, it's not just about building a road and moving cars through. What's going to be the health impact of this? Because it will have a health impact. When community developers decide they're going to build this beautiful new, I'll use Charlottesville as an example. Anyone who goes to Charlottesville, we're very proud of our downtown malls, pedestrian mall. It's a mini version of the Ramblas from Barcelona. Yeah, blocks and blocks and blocks. Beautiful tree line, top-notch, we're all foodies in Charlottesville. Top-notch restaurants up and down the other side. What most people don't know is that used to be the most prosperous black community in Charlottesville. They ripped that community apart, dispersed them to all the rural counties, and built this beautiful thing. And they didn't think about what that meant for the African American community in that town, which was decimated, and people are still feeling the pain of that disruption. And that's not unique to Charlottesville. That's true of almost every city. You can go to the area. And actually, academic health centers are notorious for that, for being built. This one got away with it because you're in an old airport. But quite often, they're built right on some old community of color. And at UVA, there's a train track right behind the main medical center, and the black communities now across that. So anyway, where was I going with that? The point is that all of these factors impact health, and therefore you got to get all of these people to the table. I think that one of the reasons why I shifted from clinical medicine to population health is that I feel that from this vantage point, I can play a role in bringing together all of those players, all of those stakeholders. I can get them to the table. And getting them to the table then gets me the opportunity to talk to them about, okay, we all have an impact on the health of, in my case, the state of Virginia. What can we do together to improve the health and well-being of this population? I think that's also the role for primary care physicians and other primary care providers in their communities, because you are leaders in those communities and can help bring those various stakeholders together. And I also, and we were talking about this a little bit earlier, I think another important thing that the people who deliver primary care can do that I can't do from my vantage point as a public health official is you can bring the stories, which are much, I can't overemphasize the importance of the stories. I can go to the Virginia Capitol building and I can sit down with a bunch of state senators and legislators and I can tell them about, show them a nice pretty map, explain to them all of these health-related social needs that the community, say in Southwest Virginia has, and if we change the amount of affordable housing, here's the likely impact on opioid use in Southwest Virginia, blah, blah, blah. Right? But if you're a physician down in Abington, Virginia, far Southwest Virginia, and you come to them and you tell that state senator who represents Abington, I want you to meet Miss Pearl Johnson. I've been taking care of her for 16 years, and you have her tell her story, that has a much bigger impact on that state senator. And together, doing things like that, I think we can move the needle and improve the health and well-being of the populations that we serve. I'm going to shut up so that we can have some time for questions, discussion. I want to hear what you think, and I appreciate your time. Yes.
I think about, probably about 7 years ago, I went to a talk by Bonzo Reddick, who was a professor at Morehouse College of Medicine, and it was kind of blowing up. He tried to find the first place where it was ever written that blacks have a different angiotensin system. And he took it all the way back to the first place that was ever noted. And, it was sort of, somebody said, well, one possibility may be this. And then that started to get cited over and over and over. But I think, at least based on the names of certifications questions that I've been answering recently, they still teach that. So, I think part of the issue is trying to get at medical educators and really the folks who are maybe not in the school but are influencing what happens in the schools. Mm-hmm. And I don't know what's being done there. I'm curious.
So my colleagues and I did that study on pain, have been trying to have some discussions with the AAMC about just this issue and trying to at least get a picture of the current state of medical education, looking at curriculum across a number of med schools just to see what's actually there and then propose some changes to it and test it out and see how that works. I'm not one of those who said you just should eliminate all mention of racial category. I think because racism exists, we need to track certain things about racial categories. We need to see whether or not Latinos are being mistreated. So you got to have that category and you got to track how they're being treated. But that's different than saying that there's some kind of biological basis for that. Just from the med schools I know, I think it's pretty rampant that there's an assumption that there's some biological difference there, and that blackness somehow is a marker for those genetic differences, which I mean, I look at my genetics, my friends who are in genetic science, you know, and I'm like, how can you think that? I mean, you know, it just doesn't make any sense, right?
Jack Westfall. So that comment just sparked something. This is rampant in all of our language. We have white papers.
Yeah.
We don't write black paper. We write white paper. But there's a blacklist.
Yeah. Yeah.
And that's the group of people who are undesirable. And how do we approach those and actually call that out when those things happen? How do you just say, you know what? We're not going to write white papers. They're position papers or reports. Or how do you go about doing that to change the culture?
That is a great question.
Well, we're looking for a really great answer.
Well, Jack, I think that I think it's important for each of us to call it out when it happens. So, like last night at dinner, we were talking about the fact that, you know, it used to be a fairly common practice in medical training, both as when you're a student or clerk, and when you're a resident, to begin in your first sentence of your report to the attending, you know, Mr. Oliver is a 67-year-old African-American gentleman who blah, 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 right? And years ago, I just started calling it out. Like, well, stop. Why do I need to know that this patient is African-American? Does it have anything to do with what you're going to tell me after this? No, well, then I don't even know. Why is it there?
Well, but I think it's also part of our education to teach in physical diagnosis class, and I don't know, I haven't been in medical school for a while, but we used to teach, and I think they still do teach, this sort of, you gave the example before, when you walk into a room, you have a Augenblick, that blink of an eye diagnosis, and we teach that in physical diagnosis. And at the same time, our media and our culture, so medical students are learning a way of thinking, mm-hmm. and it's being infiltrated with the social images coming across, and so they suddenly start incorporating those into that rapid diagnosis.
Yes.
How do we break that cycle?
It's one by one challenging it, bringing it out, discussing it, and talking about it like we're doing here. When I said that, you know, it's becoming aware, that's the first step. Once we have to understand that the majority of people explicitly are against that, right? So if you did something that was really offensive to me as a black, now, you know, what I say to you, I say, Jack, don't say that. It's really not cool. Don't ever say that around a black person, you know?
That's right. I think we've had that conversation.
You would say, oh, wow, thanks, Norm. You would thank me, right, for making you aware of it. So we have to have that discussion where people become aware of the problem. And then I think we need to develop tools to provide people that they can use as they practice that sort of self-monitoring, so that they can do the self-monitoring and make the corrections in real time. I do think it's important, however, I need to say this, because there's a bunch of people who do work around this implicit bias stuff who sort of take the attitude of, implicit bias, it's very rampant, we all have it, you know, so they normalize it. It's really, you know, not your fault. And here's some, and we can do some classes and we can talk about it, and that's that, right? If we don't understand where those biases came from and do something about changing that, doing something about the structure and the whole culture, then we're fighting a losing battle, I think. So my own opinion, and this may just be because I'm a child of the 60s, I think the reason why the majority of people in this country have a explicitly anti-racist view is because the civil rights movement and the mass movement of people fighting for black rights changed their minds, changed their heads. I grew up in Detroit, and my dad was a real big-time union guy. And I remember he took me to a union meeting, UAW meeting one day. And they're going on about different stuff. I wasn't paying much attention. They got to a financial report, and the guy started explaining the financial report, and there was a guy who was pretty drunk, stands up very upset about the amount of money that's being spent on this miscellaneous woman. Who's this miscellaneous? And he got really rowdy, and the guy who was chairing the meeting said, "Can we have the education committee?" And then these three guys come in who were about the size of middle linebackers, right? And they walk in, and they just pick this guy up, and they take him out. And I turned to my dad, and I said, "Why do they call the security people the education committee?" And he gets this big grin. He says, "Boy, sometimes the best education in the world is a good ass kicking." Right? I think social movements play that sort of role, right? They forcibly shift a society's view on things. And so I think that's what we need. I think we need a lot of people to stand up and say, that's it, enough of this. We're not going to do it that way anymore, and call it out. So things like Black Lives Matter, I think has a real impact on stuff like that, and it needs to be bigger and broader and involve more people. So that's my answer on how it's going to change. I don't think it's something that we can just legislate into being. The legislation comes after that. So it means people who are doing work in the community, for example, those community organizations getting together and demanding that, you know what, you need to treat us differently. That it's those sorts of things that force the change. And I'm looking for more of that. I don't know if that's the good answer you're looking for, but I'm going to leave it at that.
Starting on my soapbox, I say also there should be more social science and humanities than science education.
Yes.
That's beside the point. So when you're talking about the slow thinking and the fast thinking, it made me think of kind of how there's this movement in clinical settings to kind of speed up appointments, right? Because it's a money issue, right? Like you need to see more patients to see more. And do you think there could ever be a moment where that kind of push could be turned around? Is that happening anywhere? I mean, is there any kind of movement to try to slow down these patient interactions and try to make those better? Address these issues?
One part of that answer, although not the entire answer, would be changing the payment structure. So if I'm not paid for how much I do to you as a patient and how many patients I do it to, then I can take more time. So that's part of the answer. If we were to take that money-making aspect out of caring for people, and you could just care for people, then that would mean you'd bring to bear whatever you needed to do that. If it was spending an extra 20 minutes, you spend an extra 20 minutes. If it means bringing in a psychologist because this person's in a lot of psychological distress and pain, it means bringing that person in. If it means arranging, transportation for them, and then you figure out, well, it's actually not just this person, it's the whole community has this problem, and then we need to go down and talk to some folks about fixing the transportation problem in this community, then that's what you do. Because the thing you're concerned about, the outcome that you're measuring, is the health of that individual's family, that individual's community, and not how many RVUs you generated. Right? But then that gets back to what we were talking about before. I think that's going to take, it will take either that kind of social movement that I was talking about, or this whole thing just crashing down, which we're getting pretty close to it happening. And because it's not sustainable the way it is. So someone over here had their hand up. Yeah.
Another question. I appreciated your statement that a blanket policy is not going to be effective here, and you put more of your investment into raising awareness. And right now, there are a couple of these social awareness campaigns that are very prominent. And one of them that I see the effects of is the NFL protesting of the national anthem. And when we do something like that, that puts that issue in front of so many different people, I totally appreciate how that can open people up and have a different discussion. Mm-hmm. I've also seen how it can unite and fuel the opposition, so to speak, and you get a lot of people following the president's lead, and those people need to be fired or put in their place. When that happens in response to something like this, what's your approach when somebody gets inflamed and their racism is no longer implicit, it's very explicit? What do you do in those situations? How do you address those things?
Well, in a clinical, are you talking about in clinical setting?
Sorry, yes. Clinical.
Because outside of a clinical setting, I just don't talk to people like that. But it's not worth my time or theirs, really. In a clinical setting where I'm actually trying to help this person, I will actually take the time to explain who I am, what my background is, what I bring to bear in helping them deal with their situation, and that this is, in fact, a good thing for them that I'm here, and that this team is here. Or in the case, sometimes it will occur with like a student. So I'll speak up on their behalf and tell the patient, this is it. You have to accept this, and if you have to put aside those views, and we don't tolerate your expressing them. And I don't try and change their mind. It would be like if someone lit up a cigarette. I mean, they can smoke if they want to, just not here. Right? Can't do that here. That's not acceptable here.
It's so interesting to me how that is a lot easier to do clinically and to press pause on your own feelings, where if that was in your personal life, that's where this avoiding those types of people or the verbal aspect comes into play right there. And I find it very difficult to maintain that same level of patience and understanding and respect towards somebody who's doing that and say, just please don't do that around me, here's why. And I tend to go the same route you do, avoidance, or I get nasty with people.
I think you have to allow the provider that space to do just that, though. I mean, I would try and do that, but there may be other colleagues who say, I just can't deal with this, and they should have the right to just, I can't deal with this, and I'm out of here. Fine. I wouldn't force people to do that. But that would be my approach. Because I'd be really concerned if I actually helping the person out. Yes, ma'am.
I had a question in regards to the social determinants of health. This is obviously a topic that's really coming to the surface as you're thinking about healthcare and how to reduce the health inequity that's happening in its area of interest of mine. And so what I was curious about is in a clinical setting, and one of my colleagues, she mentioned how times are getting shorter, right? It's how many more patients can you see? Oh, you can see 23 in a day. What about 27, right? And so my question becomes, when you're thinking about the issues around social determinants of health, how do you best incorporate that in a clinical setting under those constraints? Because what I find and can respect from a clinical perspective is, right, once you know the information, you kind of have to do something with it. And so a lot of clinicians, oh, you just lost your job last week? I don't really want to know about that because then I kind of have to do something with it. Oh, you're about to get evicted? Don't tell me that because I can't help. I'm not interested in helping you with that, right? Or the doorknob confession, right? You just would rather not. So the question becomes, how do you engage in that kind of information? Because ultimately it does affect the health outcome, or whether or not someone is medically cooperative, et cetera, et cetera. So what does that look like?
Couple things on that. I think in the primary care setting, we need to have what some of us would call advanced patient-centered medical homes.
Oh,
Okay, so and by that I mean that the care of the patient is seen as something that a whole team does. So before I left UVA, the clinic I worked in, we had a couple social workers. We had 2 full-time psychologists, a part-time psychiatrist, a PharmD, all there, right? If the patient said to me, and I was supposed to see patients every 15 minutes, which is probably a luxury compared to what you're saying. So if a patient said to me, I'm about to get evicted, I didn't freak. I would say, you need to see Joanne.
because you had accessibility.
Right? And Joanne can hook you up with some resources that can help you out in that regard. I wish we had had some legal stuff, actually. That would have been really helpful to have some legal partnership for some of our patients. Likewise, on psychological problems, I didn't have the time often to really counsel somebody, but I could call somebody who did have the time to counsel. So that's important. But I think it's also important to break outside of the clinic. And I would argue that the clinics need to be tied into and part of the community in which they serve. Right? So that it's not just that you have a social worker who can help them connect to resources, but then that patient also sees you at the housing authority meeting with some community organization that's demanding affordable housing. Right? That's part of your caring for that community. Now, there are physicians who say that's not my job. And part of changing medical education would be to say, well, actually, it is part of your job. How can you possibly say you're taking care of this patient's family, and this patient's community if you're not doing these other things? You should be part of that. I mean, you don't personally have to solve the problem, but you do personally have to be part of that group that is trying to solve the problem, right? So the idea that we can be separate from that is a misconception that's been taught in medicine. We've been taught, like you were saying last night, right? I'm just going to deal with the patient right in front of me, and just with their biomedical issues, right? We're not going to do well by our patients and their communities if we maintain that attitude.
I had a follow-up question. I was at a conference last week on health care communication, and one of the things that came up in a session was a story from a physician, and it was on biases, et cetera, in a clinical setting. But one of the things that was interesting that she shared, which spoke to the stories, is she said she had a gentleman who was a 18-wheeler driver, a truck driver, and his diabetes was absolutely uncontrollable. And she could not figure out why in terms of medication, adherence, et cetera. And after conversation, she found that he had stopped truck driving, was on disability, and in order for his disability to be maintained, his A1C had to be within a particular level. So he had to be sick. Right, he did not want to manage it because if he managed it, his disability would stop. Yeah. Now, of course, I would not instinctively think that, right? But the question, to your point, it's not about you, it's about the patient and their circumstance and their, social situation. And so how do you, from a training, med school training perspective, get into that degree of conversation? Because that's the kind of conversation that can help you treat the patient, right? Or at least be able to operate within the scope of their situation or provide support to the extent that you can.
I think early on in medical education, we need to get the students into those clinical settings so they hear those stories, right, from the patients. Get them into those community organizations so they hear those stories. And begin to And in the beyond that, say even in the policy thing, because one of the things that could be done, for example, in that story is going to the state government and whoever comes up with those regulations and say, this is crazy. You shouldn't have regulations that force people to stay sick in order to get support, right? So all of those things are things that should be incorporated into the medical curriculum, and it needs to be done not just from a didactic point of view, but experientially. Those students need to get out and be involved in those sort of things early on. Time to quit.
Join me in thanking Tom. So, two things. Number one, please fill those evaluations out. Norm wants to know how he did. Number two, at 2 o'clock we're going to continue this conversation. If there are parts of what got raised that you'd like to hear more about, or you've got some questions about, or you'd like to have a discussion around, come over to room 3101 in the AO1 administrative building over in the research quad. And we're going to spend an hour over there from 2 until 3. And by then, Dr. Oliver's tongue will be hanging out, and we'll cart him to the airport and send him on his way. Thank you all again for coming.
Thank you all.